Good evening and welcome to Doctors on Call. I'm Dr. Mary Owen, a family medicine physician for the Leech Lake Mandeville Ojibwe and faculty member at the University of Minnesota Medical School, Duluth. And I'm your host for our program tonight on depression, anxiety, and suicide. The success of this program is very dependent on you, the viewer. Please call in with your questions and we'll do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. David Baldus, a psychiatrist with Essentia Health, Dr. Michalene Stevermer, a psychiatrist at St. Luke's Mental Health Clinic, and Dr. John Wood, a family medicine physician with Essentia Health and director of the Duluth Family Medicine Residency Program. Our medical students answering the phones tonight are Frederick Blaisdell from Dearborn Heights, Michigan, Rachel Hansen from Lakeville, Minnesota, and Hannah Thierry from Stanchfield, Minnesota. And now on to tonight's program on depression, anxiety, and suicide. Thank you all for being here.
Thank you.
Thank you.
Until we get some other questions from the audience, I'm going to go ahead and start on a couple.
Sure. Dr.
Wood, I'll start with you. So there's been a tremendous increase in suicide rates in Minnesota, up 53% from 1999 to 2017, and up 33% nationally. Given that, are there any changes in residency program curriculum to address these increasing rates? And I know it's a family medicine residency, but we are on the front line as family medicine docs.
So I would say, our family medicine residents, we have 27 residents. We train over the course of 3 years, 9 per class. And what we're trying to do, our mission is to really train docs to work in small towns. So what we're really trying to do is train our physicians, both in the present and physicians of the future, to work well with their patients. One, to be able to recognize mental illness when they see it. We're talking today about depression, anxiety, and suicide, but being, one, comfortable with diagnosing that, and two, comfortable with talking with patients about that, and three, comfortable with talking with our psychiatric colleagues when that's needed for these patients. Because the reality is that, unfortunately, there aren't enough psychiatrists to go around, and so it often calls on us to at least be able to start that treatment and sometimes continue it if we're comfortable with doing so. So I'd say that's the answer to our question. We're certainly not running away from that because we see there's a big increase at our clinic, and obviously there's a big increase statewide, locally, and nationally. So.
Dr. Baldus, you look like you want to comment on this, on the increasing rates. Are you guys both seeing this a lot more, or seeing repercussions from the increasing suicide rates? Or?
Yeah, certainly. I think during times of, it's important to think about suicide not only as evidence, say, of a specific mental illness like depression, which is often sort of a misconception that if there's a suicide attempt that person must be experiencing major depressive disorder, but rather to think about suicide as evidence of a person facing a problem that's causing unbearable suffering of some kind with no apparent solution. And suicide becomes a final solution, a tragic solution. And so what we see is increase of suicide rates with all sorts of different kind of mental illnesses, and also with cultural problems. Right. And so we certainly, as we have increases in problems like social problems like homelessness, poverty, serious economic problems, we tend to see increases in the rates of people facing unsolvable kind of problems who turn to substances, who might have worsening of mental health conditions, and then may ultimately turn to suicide. So we are certainly seeing that and doing our best to partner with our primary medicine colleagues to try to provide as much support as we can for people who are very desperately in need of help.
Well, as a person out there in the field, I appreciate that. Thank you. Dr. Stevermer, can or should patients ever taper off of antidepressants when they've been on them for over 10 years?
That's a great question. I would say that if they're planning on tapering off of medications, that they should talk with their doctor first. Yeah. That's kind of first and foremost. You want to have that discussion and you want to have support behind you so that if something happens, if your depression worsens, that you have help out there, that they know what's going on. So if you need to go back on them or go back up on them, that somebody's aware. The other concern is that you want to make sure that you're tapering in a safe way, and that you aren't just going cold turkey off the medications, because that can cause withdrawal symptoms that can be very uncomfortable as well. That being said, if it's their first depressive episode, there's some, there's more likelihood to be able to successfully taper off potentially for a while, if not forever. However, if people have recurrent bouts of depression, then it's less likely that they'll be able to taper off medications, and there's more indication that they should probably stay on antidepressants long term.
Dr. Baldus, I'll get to you, Dr. Wood.
I'm ready.
Dr. Baldus, we have read in the news that it's extremely difficult to taper off some of these medications, even slowly. So how do you manage that? Is there do you have a technique, like you
Certainly.
cut those pills down to microbits? Or?
That's a wonderful question. So it absolutely depends upon what the medication is and how the medication is metabolized by the body, and then how potent the medication is. So if a person is on a medication that's highly potent, that it has a strong effect on the brain and also is metabolized out of the system very quickly, then taper of that medication can be very difficult because it metabolizes out quickly and a person can experience withdrawal. If a person is on a lower dose of medication or have a medication that works its way out of the system slowly, things are easier.
Okay.
But a very common approach would be to transition from one of those higher potency,
Okay.
rapid metabolizing drugs to a drug that's slower to metabolize, and then gradually taper that slower metabolizing drug. So there are approaches that we can take, but it takes expertise and effort.
Okay. And as a family physician, can we easily access some of those protocols or those taper? Okay.
Yeah.
Very much so,
Dr.
yeah.
Dr.
Very
Wood.
much so. That's relatively easy for us to find. Like, there's lots of medical resources we can use.
Okay.
And I think like what Dr. Baldus was saying, we tend to go slow, and I think that's the main mantra to use, and also to be able to counsel the patients that if they are feeling certain symptoms, they need to let us know, because there's certain things that are pretty troubling, and if they go unrecognized, they can cause some real trouble. But it is challenging, but it's doable. You just have to be patient, I'd say, is really the main thing
Thanks.
there.
Dr. Stevermer, we have a question from our audience. How dangerous is electroconvulsive therapy?
Well, that's a great question. Electroconvulsive therapy nowadays is actually very safe. We do it under generalized anesthesia. So where we provide ECT at St. Luke's, there are always 4 people in the room that have eyes on the patient. They're always monitored with, their heart's always monitored, their breathing's always monitored. So they're asleep during the procedure, their muscles are relaxed during the procedure, so it's very safe. The biggest things that we watch out for are any headache, muscle aches, and then we always monitor for any memory issues as well, and we try and do some things to minimize those effects as well. But it's a very effective treatment for depression and also for treatment-resistant schizophrenia.
Okay, thank you for that. We have a question from Jim. We'll see a lot more of this in the, I think, in upcoming questions from our patients in general. CBD works on anxiety. What are some of the benefits or disadvantages?
Well, I think the big disadvantage of CBD is that it's not really been studied in a formal way, meaning that a lot of the evidence is anecdotal, a lot of the evidence is patient-specific, and there's no real way to evaluate that. I mean, I've never taken CBD. I've never told someone they should take it. I know it's readily available. I know that there's a lot of research, certainly in Minnesota. Minnesota's kind of leading the country in actually studying the effects of medical marijuana in a real systematic way, trying to get some good research done on that. And I know that those cannabinoids are psychoactive in many ways, and specifically, the evidence is anecdotal. That's really all I can say. I don't know if Dave or Mike have anything more to add.
One of the biggest concerns is that it's not regulated right now too, so you don't necessarily know good dosages. You don't know what the effects are going to be person to person, so that's generally my biggest concern, on top of as well that we don't have necessarily that good foundation and evidence base behind it right now.
I would only add that there's inconsistency in manufacturing processes, and so depending upon where you're purchasing CBD, you don't entirely know what you're getting. Now, of course, the state has sanctioned the use of medicinal cannabis products for treatment of PTSD within the past couple of years, and so I routinely have patients in my practice ask me about that. And so I think it's important for patients to understand that if they are pursuing medicinal cannabis, extracts or products in the state of Minnesota. At the dispensaries, you can get different products with varying concentrations of THC, which is tetrahydrocannabinol, or the psychoactive compound in cannabis that gets a person high, and CBD, which doesn't have the same kind of psychoactive properties. And it's really critically important that if a person is pursuing medicinal cannabis treatment for, say, PTSD, that they avoid products with a high amounts of CBD, or excuse me, of THC, and focus on products with predominant CBD concentration, and to talk to the dispensary specifically about that.
Okay, thank you. Dr. Wood, can you draw the line between supportive intervention and intrusive intervention in handling a loved one's mental illness?
That's a really good question, and it's very patient, loved one specific. I'd say that the support becomes intrusive when it becomes directive, and sometimes that's needed, but that's pretty rare. I'd say that you need to be empathetic, you need to be listening more than talking, and you need to be a guide rather than a director of whatever your loved one, whatever experience the patient would be going through. There are certain times where you need to be pretty directive. If you have someone who says they're going to hurt themselves, I think at that point the support needs to be a little more directive, because you should take any threat of suicide pretty seriously, at least as a layperson, till you can judge adequately what will happen or won't happen. And so I infer from that question that this is a tricky thing. And I would say supportive is, you need to be less intrusive. You can't be directive, you need to listen and be empathetic. And that'll usually tell you the answer for most people.
Thank you. Dr. Stevermer, if you're on antidepressants for a long time, does that increase your risk for Alzheimer's disease?
Ooh, so that was a new study that came out recently that indicated that more people with Alzheimer's had been on antidepressants long term. However, it's tough to tell causation versus whether people with untreated depression may be at more risk for Alzheimer's as well. So really we're going to have to kind of follow the research coming through and learn more about it and what may be causing risks for Alzheimer's. I would say, though, that untreated depression causes significant health risks as well, including increased cardiovascular issues, and those are all concerning for long-term health for patients.
Dr. Ballas, did you want to add anything?
I would just echo that. So
okay.
There's a trend in medical research to use large population studies with wonderful population health databases, and to mine those databases using modern computer-guided statistical kind of analyses to derive statistical connections. However, many times two problems can be correlated and have a similar root cause. And so, for instance, we know that major depression is a serious disturbance of brain function, and dementia, of course, is a neurodegenerative brain disturbance. And it may well be that major depressive disorder and dementing illnesses have a common origin or a common genetic driver that predisposes a person to both. And so we need to be very cautious when making those kind of connections.
Excellent point. Dr. Wood, what can I do to increase my mood in the wintertime? Duluth.
Today, I mean, yes,
right.
Today was pretty nice. Saturday was a little rough, or Monday was a little rough, I'd say.
Quit avoiding the question, Dr. Wood.
What?
Quit avoiding the question.
Yeah, okay. See, we're talking seasonal affective disorder probably.
Right.
It's a fairly common thing up in the northern latitudes. There are certainly lights. You can buy lights that have a broad spectrum that you can use. And 10,000 lumen light can help, and those are readily available. You can buy one on Amazon. We have a bunch of them at the residency program, help our residents. Exercise is a big thing. You need to get outside. People need to be active. They need to be aware that they need to find some way to get active in the winter months. And that's really means, and that's patient specific. It's not going outside and running. It might be walking in the mall. It might be going to Anytime Fitness. It might be swimming. It might be just doing something active, I'd say, are the two biggest things. And to be aware that, and usually the best prevention for seasonal affective disorders is to start earlier than you'd think. You get that light going in the fall. Some people take an antidepressant in the winter. And they started in September as opposed to December when the days are shortest and it's already a little too late to do anything. You want to try to ramp up for that rather than wait till it's actually on top. Because most people who have this know they have it, and they're aware of the symptoms, or their spouse or their partner is aware that in the winter it's a little tougher for them. So those are things I do.
In that short-term use then of the antidepressant, if you just use it in the winter, do you need to taper off still? Do you still require taper, and how slow does it have to be?
Again, that's specific to the patient, I would say. Would you be thinking, I'm thinking September through, April, May, the days are longer. We've had patients, we've used that for, I used to use that up north when I was in Grand Marais, so.
Dr. Stevermer, what's the difference between sadness and depression, or grief-related depression we often hear? When do you decide to say, okay, this is really depression, we need to step down and treat it?
So the DSM says that major depression happens after 2 weeks of significant symptoms. You have to meet like 5 out of 9 criteria, including disturbance of your sleep, lack of interest or loss of interest in things you like to do, feelings of hopelessness and helplessness, decreased energy, decreased concentration, appetite issues, psychomotor slowing, and then suicidal ideation. So typically, if they meet 5 out of 9 of those criteria, then what we look at there is, do they need treatment at that point? How severe are their symptoms? And then we look at what intervention do they need. Do they need like a therapy intervention, or is it severe enough that we need to consider medication at that point? What becomes a difficulty is when people come in with grief, if they've lost a loved one. And at that point, it's patient specific. We've been talking about that kind of all night. You have to kind of assess the patient themselves and whether what they're feeling is a normal amount of grief, because grief isn't something that's standard for every single person. It's different for every person about what they can tolerate. However, if their symptoms of grief are severe enough that they aren't able to function in their day-to-day life, that's where we consider it as more severe than just sadness or grief, and consider it more as maybe we need to treat this as a major depressive episode.
Thank you. All right, Dr. Baldus. Oh, it's specific to Dr. Baldus.
Am I?
Do you or anyone use gene site testing?
Okay, wonderful question. So,
did you plant this question?
I did not, and I'm not presently using gene site testing, but I have historically and can speak to that. So GeneSight is a specific vendor for genetic testing to try to assess a set of genes that a person has that might impact antidepressant response and antidepressant tolerability, and actually psychotropic drug in general tolerability. So this testing looks at a couple of things. First, it looks at the set of liver enzymes that are responsible for metabolizing a number of psychiatric drugs. And it assesses whether those have average level of function, higher than normal level of function, or lower than normal level of function. And if a person has higher than normal level of function, then the drugs might be metabolized out of their system more rapidly than an average person, and they might need higher doses, or they might be less likely to have a response. If it's lower than typical activity of those enzymes, then they might develop side effects at lower doses and not be able to tolerate medications. Now, there's a second set of genetic tests that have, I think, a little bit less robust evidence-based that look at certain genetic changes in things like the serotonin receptor that might predict how a person responds to certain antidepressants, like, say, an SSRI medicine like Prozac. And so at this point, this is an emerging field. Insurers are coming on board and paying for this testing, and it certainly can guide treatment. And the evidence is still out there. There's some evidence to suggest that it has some marginal benefit for predicting and improving antidepressant treatment response, and other studies say it's very effective. And so I think you need the testing, and then you also need a well-educated provider to interpret those testing results and not just look at a report and say, these drugs are green in the green column, that means they'll work. These are in the orange, that means they might not work, and these are in the red, don't give them. So like any medical testing, I think it depends upon interpretation, but it can be very valuable.
Yep. Very interesting.
I think just to piggyback off of what Dr. Baldus said, even though it tells us that people might have high activity of those genes or low activity, it doesn't necessarily mean that those medications would be less effective. It means that we need to change the dosage on some of those medications. And so it doesn't give us this great picture of, yes, this medication is going to work fantastically for you. It might just mean that it's more tolerable for you, but it can guide some decision making and make things less uncomfortable for patients. It might lead to less side effects. So.
Very interesting.
And we've also used that too at the residency, where we have a patient that has not responded to several different SSRIs.
Right.
And so is there something else we can maybe try or think about dose adjustment, like you said?
And I will comment, we do have some quick and dirty methods for assessing enzyme activity. We have some older antidepressants that are metabolized by a common enzyme that metabolizes many of the other ones, but has measurable blood levels. And so in cases where one can't get insurance coverage for that testing, there are ways to sort of work around that using a drug that has a measurable blood level and established therapeutic ranges. As it turns out, those medicines have measurable blood levels because they are a little riskier, but can be very effective as well. So,
Very clever.
yeah.
Interesting. All right, so what are some signs that someone could use some help, Dr. Wood?
Well, meaning we're probably thinking about more urgent intervention. I think we're maybe talking about someone who might have expressed or vocalized or demonstrated that they might be thinking about hurting themselves. And so you'd think about intent, plan, and then means. Do they have the intent to hurt themselves? And the plan, have they thought about that? These are questions you might ask the patient in the room. And do they have the means to do that? For example, I was talking to one of our behavioral health therapists, and certainly someone who's a diabetic could stop taking their medication, insulin, for example. That would certainly maybe lead to a lethal outcome, but it might take a while. Right. Where if you have access to a firearm, you can hurt yourself pretty quickly. And I think I think firearms are something you do need to talk about in the context of suicide, because in 2016, I think 4 out of 5 deaths from firearms in the state of Minnesota were from firearms.
Okay.
And so this is an easy way, and very, in our culture, a hunting culture, it's very easy to find a weapon if you're so inclined.
Okay. All right. Anxiety is often treated with antidepressants, Dr. Stevermer. Why is that?
So the antidepressants typically also have an anxiolytic effect. Serotonin things act in anxiety as well, and so by modulating that, it can really help in anxiety. Also, I see in a lot of people, I see a big connection between anxiety and depression, where as we get their depression treated, then their anxiety improves. And I think we had a question earlier about ECT. ECT is not a treatment at all for anxiety, but I have seen that as we treat some people's depression, that I do see sometimes their anxiety getting better in certain people. And so as we treat that depression, sometimes that also helps treat that anxiety.
Okay, thank you. We have an important question that many people are concerned about, and that's how can we encourage, Dr. Baldus, how can we encourage friends or family to seek help?
Well, I think it's important to come to anyone who you believe needs help from a place of love. People who are experiencing depression oftentimes have internalized quite strong feelings of self-loathing and of shame, feeling lack of worthiness, and often perceive that they may not be worth the care and attention of people around them. And the tricky part about depression is it certainly can skew the way that we take in information. And so when we approach a family member who is in need, even as we express sincere concern, if we do so in a manner that a person might perceive as judgmental, they may well take that as just more evidence that they are, say, unwelcome or burdensome. And so coming from a place of love, speaking to a mental health expert even before approaching a person is not a bad idea to try to get some guidance. But I think by and large it's coming to a person from a place of concern and care and non-judgment is critical, because people will withdraw and push away if they perceive judgment.
Dr. Stevermer, do you have anything to add to that?
I think also meeting people kind of where they're at. So are they ready to seek help, and seeing where they're at in in their depression, in their mood, and where they're at in their readiness for change. You know, if they're expressing thoughts of self-harm, then that's obviously something where you'd need to step in a little bit sooner and try and seek more active help. But if they're considering getting help, then asking them what their concerns are about getting help. What are their fears? You know, a lot of people are worried about either people thinking poorly of them, or they're worried about, you know, even finding that help or going to a therapist or to a psychiatrist, or whether medications will have side effects and things like that. And so even just talking to them about what their fears are and trying to kind of allay those fears and support them in making that decision and making that first step.
Dr. Wood, do you ever have family members who come to you concerned about one of your patients?
Oh, most
and how do you handle
definitely. That's pretty tricky.
Yeah.
I'll tell you for two reasons. One, because you have this nugget of information that is potentially very helpful to this individual, or in your approach or the help for the individual, but it's information you can't share with the patient because that's not fair to the person who told you, because it's usually told in confidence. So I'd echo with Dr. Baldus and Dr. Stevermer said, that you approach that person with a sense of love, but with an increased knowledge and empathy that you know something that is potentially very important and also can be very helpful to this person. There might be ways to ask a question. I certainly in those situations often don't let go, meaning it's going to take a little more time. I agree that you have to wait till people are ready, but you can have a heightened awareness that there's a little bit of urgency with that awareness, if that makes sense. So.
Well, thank you. Those are excellent questions from our audience, and thank you so much for helping us out tonight and answering these really critical issues on anxiety, depression, and suicide. I want to thank our panelists, Dr. David Baldus, Dr. Michalene Stevermer, and Dr. John Wood, and our medical student volunteers, Frederick Blaisdell, Rachel Hansen, and Hannah Thierry. Please join Dr. Paula Tremulin next week for a program on women's health and female cancers, when our panelists will be Dr. Haley Meyer, Dr. Sandy Stover, and Dr. Verna Thornton. Thank you for watching, and good night.